Welcome, everybody. And today is our third in a series of discussions around cancer screening. We had prostate. What do we have? Lung, breast, and colorectal. So today we're focusing on lung screening, and I'm really excited by the panel that we have today, and I look forward to a rich conversation. We have Dr. Misho Hubka. Is a robotic thoracic surgeon specializing in thoracic oncology of the lung and the esophagus. He leads the thoracic department at Virginia Mason in Seattle. He also serves as the executive medical director of the Center for Digestive Health in the Pacific Northwest region of CommonSpirit. Thank you for joining us today. We also have Dr. Suchitra Pilli, who is an assistant professor of interventional pulmonary and critical care at Creighton University and the medical director of respiratory therapy of CHI Hospital there in Omaha, and an active member and contributor to the American Association of Bronchology Interventional Pulmonary. Dr. Pilli will be starting a conversation. Afterwards, we're going to have a panel discussion, and we have Dr. Coy with us, who is a diagnostic radiologist at Virginia Mason Medical Center, and he also serves as the chief of radiology. We have Dr. John Chelico, who is a system VP and CMIO for the physician enterprise. Last, but certainly not least, joining our panel later today will be Dr. Peter Emanuel, who is the co-director of the Cancer Center, CHI St. Vincent's Little Rock, and is also our system physician vice president for the Oncology Clinical Institute here at CommonSpirit. And if I keep talking about introductions, we'll never get done. So why don't we start off, Dr. Pilli, with your slides.
Good morning, everybody. This is an exciting topic that I'm very passionate about. We're going to talk a little bit about lung cancer screening today. And next slide. And next, please. All right, so the objectives of the talk today are going to be really who should be screened for lung cancer. What are some of the things we need to know about who should not be screened? What is the evidence available so far? And if you want to implement a screening program, how do you do it? What are the barriers that we can expect? And a little bit about how we do our nodule clinic here. Let's talk a little bit about who should be screened. So a lot of the evidence that we have today and what we've been doing in lung cancer screening is based off of the National Lung Cancer Screening Trial research team and their work. So what they said, or what they did, was published in 2011 in NEJM. It was a prospective randomized trial, a lot of patients. The N was about 53,464, as you can see, across 33 centers in the United States. So a very robustly done trial. What their hypothesis was that low-dose CT screening will reduce lung cancer mortality. And their evidence, I'm going to talk a little bit about. Next slide. So really, their comparison was a low-dose CT screening versus a chest X-ray. And they identified patients based on risk for lung cancer. And their definition of this was based on these factors that are listed here. They selected patients between age 55 to 74, more than or about equal to 30 pack years of smoking history, or active smokers or former smokers who quit in the last 15 years. They do have to be fit to undergo surgery, and they define this by some of these criteria I've listed, their PFTs, their FEV1, some of those criteria, a basic cardiac evaluation, STS scores, which are thoracic surgery risk scoring systems. Next slide. All right, so when we look at the results versus the low-dose CT versus the chest X-ray, again, robustly done trial. They identified 356 lung cancer-related deaths in the low-dose CT group and 443 deaths in the chest X-ray group. So really a little bit more in the chest X-ray group, and that really translated to 20% relative reduction. And when I said a little bit more, the raw number looks not very different between 356 and 443, but when you really look at the relative reduction, that's a 20% reduction in lung cancer mortality. And for a long time, we really haven't had this sort of relative reduction in any kind of intervention in lung cancer. So this was really practice-changing data. And overall mortality in the low-dose CT group was also about 6.7% decreased. The number needed to screen was about 320 people to prevent one lung cancer-related death. Next slide. And this slide, what it really talks about is, if you look on the y-axis on the top, it is the cumulative number of lung cancers that were detected and the years since randomization on the x-axis. And if you really look at it, the number of detected lung cancers was higher in the group that was screened with the low-dose CT compared to the chest x-ray, which is the lower red line. And then if you go to the bottom graph over there, it says it's got number of lung cancer deaths on the y-axis and the time or the year since randomization on the x-axis. And you can see that the chest x-ray group, which is the red line, had more number of lung cancer deaths. So about 443 versus 356 that we just mentioned. And really, if you talk about nodule detection with a positive screen, really, I mean, 24% nodule detection in the low dose group versus about 6.9%, which is significantly, higher. But we do have to think about this with a little caveat of what is the false positive rate, right? The false positive rate in the low dose CT group was about 96.4% versus 94% in the chest x-ray group. And we really have to focus on, how many of these patients are we identifying that are then proceeding on to get invasive procedures that they otherwise would not have gotten or did not end up having lung cancer. So that is the caveat that you have to take when you look at these graphs from this trial. Next slide. And this is a little bit of the raw numbers that, kind of show the data that I just mentioned. And if you look at the time zero, that was at the time of randomization. T1 was at the end of 1 year. T2 was at the end of 2 years. And really what I would focus on is the total number screened and the positive result, right? So with the chest x-ray, you can see it was about, if you look at clinically significant abnormality, not suspicious for lung cancer, probably about 785, versus on the left side, if you look at clinically significant abnormality identified by low-dose CT, not suspicious for lung cancer, 2,695 at time zero. And as time progresses, that number consistently remains high in the low-dose CT group. So those are some numbers I would look at in this graph, in this table. Moving on. And this is another, pretty busy table that they presented in this trial. Really what I want to kind of hone down here is the number of invasive procedures, right? So if you look at the low dose CT group and the X-ray group that was, in the bottom, so focus on the fourth column that says the number of invasive procedures. And it's about 31 positive screening results for which all of their diagnostic information was complete, and they ended up getting invasive procedures, right? So 31 patients. But if you go down and look at the X-ray group, the positive screening results for patients where everything was completed in terms of diagnosis, about 15 invasive procedures. So it may end up that if you look at the real raw data, are we really doing twice the number of procedures? And so when the study came out, yes, it was practice changing, but you really have to think about, are we doing harm to patients by extra procedures that were not really indicated for these patients? Moving on to next slide. I want to touch a little bit now on, once you identify these CT guided nodules, what do you do with them, right? So there are two real guidelines available that we follow in our lung cancer screening world. One is the lung RADS, and the second is the Fleshner guidelines. The Fleshner guidelines are for incidentally detected nodules. Somebody went to the CT scan for abdominal pain and somehow got screened from head to toe. It's not very uncommon that they get a chest, abdomen, pelvis scan, and now you find a nodule and they get sent to either a pulmonologist or their PCP. The Fleshner guidelines are used for that. They don't address how to manage these nodules that are new or growing. Usually patients older than 35, there's really no upper limit. You can use it for anybody over the age of 35. And they don't apply to immunosuppressed patients or those who have already had cancer because those risk factors are a little bit different than incidentally detected nodules. Now on the left column is what we're going to focus on. The lung RADS are what we use for nodules in the setting of low-dose CT screening. That guides you for the management of nodules that are new or growing in size. These are the patients that were, lung cancer screening guidelines per the screening task force, 55 to 80. and applies to all patients who got the low-dose CT screening. Next slide. All right, so this is one slide that everybody is very, very familiar with, and these recommendations are what we follow. The U.S. Preventive Services Task Force, it's a grade B recommendation for annual low-dose lung cancer screening CT, and the population that they recommend is asymptomatic patients age 50 to 80, 20-pack years smoking history, and quit smoking sometime in the last 15 years, or they're current smokers. When to discontinue screening, according to their recommendations. If the patient quit more than 15 years ago, then you don't need to screen these patients. Their risk of lung cancer is just as it would be for the general population. So they don't come under the high-risk screening population anymore. Or their life expectancy has a life-limiting health problem. They have EF of 15%, they're multiple comorbidities, their lifespan is less than 1 to 2 years, or even less than 2 to 3 years. They don't really give a recommendation on that. But if you feel like in your judgment the life expectancy is limiting, or they're really just not a surgical candidate, we don't recommend screening. Next slide. Now we want to focus on a little bit of who should not be screened. Both the NLST trial and the Preventive Services Task Force kind of agreed on these. And I would say the Preventive Services Task Force recommendations were strongly based on the NLST data when the study came out. So if you have a history of lung cancer, your risk of another nodule that develops is completely different, and you approach that differently. You might biopsy those a little bit more earlier. You might do a PET CT scan and completely approach that differently. So those are excluded. If you've had a CT chest in the last month, that's a regular CT scan with a little bit more radiation exposure, but you've had an image done, you don't screen them again in the same annual year. Unexplained weight loss more than 15 pounds, or they're coughing up blood, that's a patient that is symptomatic and therefore doesn't fit criteria for screening. If you have low life expectancy, we mentioned that before, those patients are not candidates for surgery or screening. If you cannot undergo, or you're not willing to undergo surgery or even the screening procedure, we don't do it for those patients either. Next slide. This is annual screening that we're recommending. So we have to be a little bit concerned about patients being concerned about radiation exposure. I frequently get questions about, will the number of CT scans that we're doing cause problems? Will it give me a different kind of lung cancer? Or will it give me, something else like breast cancer, or increase my risk for, brain tumors? I get all kinds of questions. So really, if you look at it, the low-dose CT protocol, it confers very low radiation. The background radiation that we live with every day on Earth really is 3.2 millisieverts annually. And a low-dose CT, as you can see, is about half of that, right? And the extra radiation exposure from low-dose CT amounts to maybe 6 months of background radiation added on to what we are normally exposed to. And really, the lifetime radiation exposure from low-dose CT, if you start from the age of 50 and go all the way up to 80, does not really pose risk for other lung cancers. But this is a question that we frequently get, and so I wanted to really, mention that as well. Next slide. So a little bit of recap on, what are the recommendations, and they have changed over time. Current smokers or former smokers, initially our recommendation was from the NLST trial, 30-pack years. As you see at the bottom, these have changed. Quit more than 15 years ago, asymptomatic, no comorbidities at all. And these comorbidities should not preclude a curative surgery such as lobectomy or segmentectomies. And the patient should really be willing. It is a shared decision-making where you have a conversation with them as to, if we find lung cancer, what is the next step for you and what's the best, pathway for you. And that really differs from patient to patient. Going over a little bit again, the NLST trial, 2011, very well done NEJM study. Their age group was 55 to 74, and they chose about 30-pack years. The Preventive Services Task Force had a 2021 update. 50 to 80 years was their recommendation of age group. 20-pack years smoking history, asymptomatic, current smoker, or somebody that is quit in the last 15 years, not more than 15 years ago. The CMS, which, is important because, again, a lot of patients are going to ask you, is this covered? Is this going to be covered until I turn 80? And I tell them, it's going to be covered until you turn 77. And after that, it's really, again, a shared decision making between you and the patient if you want to do this for another 3 years or not. But CMS came and said it's a 2022 update that they had 50 to 77 years coverage from Medicare, 20-pack years smoking history, asymptomatic, and the same current smoker or quit in the last 15 years criteria. Next slide, please. All right, now I'm going to shift gears a little bit and focus on what are the components of a lung cancer screening program. This is a topic that you can talk about quite a bit, but these are really some of the big gun things that you're going to aim at, right? You have to, I'm going to start at the top and kind of go in a clockwise fashion. If you look at smoking cessation, that is your, it's got to be a cornerstone of the program. You have to talk about this. You have to have some sort of a smoking cessation program at your center that you can refer these patients to. A lung nodule management algorithm based on lung RADs. If it's an incidental nodule, you want to incorporate those Fleshner guidelines and have an algorithm that you've developed that works for your patient population. A structured reporting system. There is a lot of AI integrated systems that are now available that a lot of healthcare systems are looking into for structured reporting of these risk factors. There is a concept of radiomics that we can talk about a little bit as well, where AI and radiomics sort of interact with each other. So there's a lot of that we can incorporate into a screening program. And lung nodule identification. You really have to decide, are you going to go after a screening program, and there are some healthcare systems that are just going after incidental nodules because it's easier to establish. But again, that is a problem that we talked about. They're not the high-risk population, and you have to ask, is that the right way to do it? So I think, focusing on the screening population makes a little bit more sense. After you identify the lung nodule, you really have to talk to your radiation department and talk about how the CT scan is performed. And you have to have protocols developed for your low-dose CT screening. And at this point, I think most hospitals have this. And how often to screen, how long to screen these patients for, a little bit of shared decision-making and individual patient risk factors have to be considered, and therefore resulting in proper selection of your patient population for screening. Once you have that, really the next step of developing a screening program is to have a central location and a nurse navigator to really say, what is the workflow going to be of identified nodules that are, high risk and in a smoker, what are we going to do about this? And significantly important consideration would be, are we going to send them to a pulmonologist? Are we going to follow lung labs and continue with the PCP? And this really differs from place to place. And if you establish a lung cancer screening program and plug these patients in there with an established algorithm, that is probably the best way to approach it from a healthcare system standpoint. Next slide, please. This is a slide about, the American College of Chest Physicians and American Thoracic Society had some policy statements that came out in 2015. And their rationale was, little guidance has ever been provided to any sites that want to develop a lung cancer screening program. And their objective was, how to promote successful, safe implementation and effective programs. And this is a really interesting article. If you read them, they have an official statement on this. But I will say this is I know we're going to go over this a little bit later as well in the talk, but it's very variable across institutions at this point. Next slide. So again, the same thing, there are components of the lung cancer screening program. The summary from that statement was, who is offered screening? Determine that first. Determine eligibility. How are you going to do the outreach for these patients? How are you going to establish shared decision-making in a clinic environment? And how do you risk assess these patients? How often and how long to screen? Again, annual screening until 80 years age. What about how do you identify new problems that are now causing life-limiting expectancy? If somebody else gets colon cancer and, at the age of 75, are you going to continue screening them if they have had, massive health effects from that? How is the CT scan performed, right? A non-contrast enhanced low-dose CT scan is what they recommended. And they had some sort of guidelines, but a very sort of a rudimentary program recommendations that they had, nothing that was very detailed. Next slide, please. Some of the components were, lung cancer identification. They determined a positive screen interpretation was 4 millimeters by the NLST standards and 6 millimeters by the lung RADS criteria. And then management algorithms, they recommended, use the lung RADS and standardized algorithms. What is the availability of procedures at your institution? Establish those criteria. Is it going to be interventional pulmonology? Is it going to be thoracic surgery? Is it going to be interventional radiology? How are you going to establish a workflow between these multidisciplinary approaches to this? They did recommend, again, smoking cessation programs, patient education, and all provider education, consistency in that as well. The availability of smoking cessation program and the integration with the screening program is very important. Outreach to PCPs and integrating them into the lung cancer screening program is important, and pass on educational materials. So all of this were their recommendations in that statement. Next slide. I want to talk a little bit and touch base on smoking cessation. Now, current smokers definitely have increased lung cancer-specific all-cause mortality compared to former smokers. So if you quit more than 15 years ago, your risk for several things goes down. And former smokers in the control arm that were abstinent for at least 7 years had a 20% mortality reduction. But remember, this is all-cause mortality that they looked at. And the combination of smoking abstinence and low-dose screening, really results in a significant reduction in lung cancer-specific mortality. So again, looking at the slide, I really wanted to put that graph down there to say, if you incorporate smoking cessation programs, your success rate is going to be significantly higher. This comes with challenges. Next slide. So I want to present some data. This is from Omaha and hasn't been published yet. So very raw data that we just got. And we took about 91 patients with a median age of about 64 years. And we looked at their smoking data provided by Epic. And we used about a 5-questionnaire algorithmic smoking history assessment, and we called it about ASHA data. And if you look at the questions really were, one person having an interaction during the clinic visit that said, how long did you smoke for? How many pack years? When did you quit? And, so and so. And it really incorporate that data at the current clinic visit into Epic. And then we did a comparison. So the algorithm data that we used had statistically greater cigarettes per day, more number of years smoked, and more pack years, right? And more importantly, 29 patients that out of the raw data, which is 31.9% of the patients, were considered eligible for lung cancer screening via the Epic data that was available at the start of the clinic visit versus 61 patients or 67% when the algorithm was used in clinics. So look at the difference between 32% and 67%. Granted, we only did this for about 91 patients, but even a representative data like this on a larger scale really does not exist. And this shows the importance of documenting smoking data very accurately. So I think that's another implementation step and an intervention step that we need to consider in our lung cancer screening programs. Next slide. And a little bit of, comment on risk assessment models that are available out there. Pretest probability, really we determine into 3 different categories: less than 5%, which is low risk for lung cancer, 5 to 65%, or more than 60%, which is high risk. And we have a few models, Mayo and Brock model being the 2 most common models that people use for pretest probability of lung cancer for each nodule that we identify. Next slide. And again, barriers, right? Talking a little bit about barriers, I just wanted to divide them into 3 different things. When you start a lung cancer screening program, there's patient factors. Patients are anxious and they have limited access to healthcare. They may schedule the CT scan. Do they have the transportation there? Do they have the family support? And there is a component of mistrust of the healthcare system about why do I really need this many CT scans? There's provider factors. There's time demands. And, Epic throws this thing at us, but then there's 6 different things I got to fill out even in that order that is, pops up in Epic. Lack of awareness among, a lot of providers really, and training and shared decision-making and individualizing these guidelines to the patient. All of these are provider factors. There's a lot of system factors that we encounter. Limited amount of equipment. Do we have the capability to get the biopsy done? What is the time to biopsy in several places? Really lack of support from the system or a lack of understanding of how a lung cancer program is very, very essential, but also has a lot of components to it. The financial commitment that goes into that. Again, inaccurate smoking history, as we just pointed out from the study that we just did. Next slide. And then you got to talk a little bit about cost effectiveness. Low-dose CT costs about, $81,000 per quality year of life gained and $52,000 per life year gained. So, it's expensive. It's most cost effective in the high risk and the highest quintiles of risk. Current smokers between 60 to 69 and more so in women. Next slide. And a little bit at the end, I do want to mention about what we do in Omaha. We do have a lung cancer nodule-focused clinic that is available, and we're working on, creating a lung cancer screening program in collaboration with thoracic surgery. But what we have currently is a lung nodule clinic that's dedicated, twice a week and 2 half days to new patient referrals for lung nodules. And we give multiple, educational talks to primary care providers in the area periodically. And all incidental lung nodules or low-dose CT screen nodules are seen in this particular clinic. It is staffed by 4 attendings. We are advanced bronchoscopists and interventional pulmonary attending combination. And symptomatic patients with lung nodules on a CT chest are also seen. So it's really all comers in this particular clinic that we have. The turnaround time here in Omaha is about 7 days. You send us a referral, the patient will be seen within 7 days in that clinic. And after that, our time to procedure has been consistently less than about 10 days. So from the first time we identify your nodule in a high-risk patient, within about 2 weeks, it's most likely that you're going to have a diagnosis and a referral to an oncologist or a thoracic surgeon, as the case may be. There's 2 dedicated, interventional pulmonologists, myself, Dr. Depew, and then 2 advanced bronchoscopists as part of our team here for this particular nodule clinic.
Good morning, everyone. Thank you, Dr. Pilli, for the why and somewhat the how of lung cancer screening. I really appreciate being invited, and greetings from rainy Seattle. In the Pacific Northwest, we are in the midst of solidifying and unifying our lung cancer screening program. And this part of the presentation is really meant to describe the challenges we faced, and I think sort of the how does one go about designing a unified lung cancer screening program. Like the rest of CommonSpirit Health, we face challenges which I'm sure are similar to your region. We have physicians located in various parts of our state. We have physicians who are employed. We have physicians who are affiliated. We have radiologists who are employed and own our own radiology centers. And then we have affiliated radiologists. And we have different parts of our state that are more urban, some are more rural, and patients who enter the system through various entry points. And so we try to be thoughtful, evidence-based, and inclusive as to how we design our lung cancer screening program. The first is we set out a timeline, and if we can go to the next slide. And the timeline really started with a visioning event where we got together with various specialists, ranging from primary care, radiology, thoracic surgery, pulmonary medicine, as well as our administrative partners, and set out the vision for our program. And then we divided the work in specific work groups. We try to evaluate our diverse electronic medical records. As the rest of the country, we are both on Epic and Cerner in the Pacific Northwest, and come up with software solutions as how to track, and then standardize our process. And finally, our goal is to go live with a unified program in April of 2024. If we can go briefly to the next slide. So the group came up with a vision statement that Virginia Mason Franciscan Health will have a lung cancer screening program, which is driven by a multidisciplinary team of experts collaborating to improve survival and outcomes of patients with lung cancer. And it sounds like a generic statement, but really it got a lot of buy-in and engagement from the various parts of our state. Next slide. And this is really the commitment and the bulk of the work that was done by my colleagues and myself. First, we formed a steering committee, which had obviously thoracic surgery, interventional pulmonology, and our lung cancer screening navigator from Virginia Mason downtown, Christine Bourrier. And then we separated the work for to enrollment and scheduling, where we engaged our primary care partners and tried to alleviate some barriers to enroll patients in lung cancer screening. Then the screening process itself, which was led by Dr. Coy, who will be on the discussion panel later today, which is how we actually transfer images and how we physically screen patients in places which are closest to home. And finally, how do we agree of intervening and tracking and multidisciplinary evaluating our patients with positive findings. And really the bulk of my presentation is my last slide. If you can go to the last slide, which really describes the process. And I'll spend some time on this. So firstly, we need to identify eligible patients. And this is, we're finding more difficult than one would think. And the crux is figuring out the patient's smoking history. It is quite difficult to actually predictably record pack year smoke by the medical assistant who checks the patient in for the doctor visit. This event then can prompt automating identifying the patient and tagging them to be eligible for lung cancer screening. And Dr. Pilli very eloquently described the inclusion criteria, which now are up to 77, went down from 80, but the pack years and the pack years required decreased. And then the patient undergoes shared decision-making in their respective community and, of course, smoking cessation. As the patient is then locally enrolled in a lung cancer screening program, one of three things can happen. Either the patient does not have a nodule, which is most of the time, but that patient then needs to be tracked by some sort of a software which interfaces with Epic and Cerner and then re-enrolled in the program the following year. And that is, again, more difficult than one would think because there's a real attrition and really opportunity lost to save a life later on, because just because lung cancer is not identified on the index screen, it can be identified on a subsequent screen. And then patients can either have a concerning nodule, which is about 15% of the time. That doesn't mean that the nodule has to be intervened upon, but it means that it has to be evaluated in some sort of a multidisciplinary way. And this means different things in different parts of our organization. In tertiary medical centers, we have nodule boards, which have all the key clinicians and all the key experts present. But in more rural places, not all the specialties are available. And this can be done either remotely, or we try to benchmark the quality event that has to happen, but not necessarily dictate the process that has to happen in different parts of our organization. We are blessed because we have 6 thoracic surgeons in the Pacific Northwest. We have multiple interventional pulmonologists, 2 in Seattle, 1 in down in Tacoma. And so we have multiple entry points in our system where patients can get appropriate care. And so we try to strive for patients to be treated the closest to home. However, we also learned that a lot of our patients enter the system through our urgent care and emergency rooms, and they have various incidentally discovered nodules, and these nodules need to be tracked as well. These are different group of patients than patients who are enrolled in lung cancer screening, but nevertheless, these nodules have to be tracked and evaluated. And as such, we are both able to achieve buy-in from the various parts of the organization. We're able to benchmark quality events that have to happen and really try to overcome some of the electronic and geographic barriers that our organization faces, just like the rest of our CommonSpirit Health organization. And so I would encourage all of you in the different parts of the country to work together both in the more tertiary setting and primary care setting in the rural areas to enroll more patients in our lung cancer screening. Thank you very much for your attention, and I'm looking forward to our panel discussion.
Great. Well, first of all, thank you both very much. That was, I think just a very thoughtful and thorough discussion about, first the benefits of lung cancer screening and the challenges that we face in actually, performing this type of work. And so I'll just generally open this up for comments or questions to our illustrious panel here, and then maybe we'll look at some questions that might be coming in. Does that make sense, Gary?
It does, and there is one question now that sort of touches on what Dr. Hubka just talked about. It says for rural areas, our patients are 4 to 6 hours from a center that could have a lung nodule clinic during the winter. Travel over the mountain passes is not possible for many. It would help us if patients could be seen remotely in lung cancer nodule clinics. And so in the background, we've all been texting about, how could we sort of standardize this across the country with our existing centers? So any thoughts about remote care? And I know, Dr. Hubka, you sort of touched on that right at the end.
Absolutely, Gary. It's a great question and a ubiquitous problem in Washington State, where we oftentimes see patients remotely across the mountains, and we have mountain passes which generate just the problem you described. I think that the key is when a nodule is identified. So now with essentially it's a first iteration of AI, which is lung rats, and it's a software that identifies concerning nodules. Not every nodule obviously needs to be intervened upon. So multidisciplinary assessment by thoracic surgery, pulmonary, and radiology, as we do in our nodule board, is paramount as the first step. A lot of these nodules just are essentially downgraded to radiographic follow-up, and that patient never needs to see a specialist. If the patient needs to see a specialist, that of course can be done over telehealth. But the important thing, I think, is that as our physician enterprise embarks on lung cancer screening and a primary care provider enrolls that patient, and there's a positive concerning finding, that primary care provider, even if they're living and taking care of patients in a rural area, has a specialty resource wherever in the region appropriate to bounce the nodule off of that resource and then get feedback as to what to do next. And I think, whether telehealth or in-person visit, it really has to be value-added and appropriate. And more often than not, the multidisciplinary nodule board, which can be all done electronically, just states that patient needs, a radiographic follow-up of the nodule rather than a visit. And so I think that will help us to, I don't want to say downgrade, but to minimize the travel burden for our patients residing in more rural areas.
Great.
Yeah, I would agree with him. And so in Nebraska, we have, a lot of critical access hospitals and a lot of, patients that really don't have access, or they have to travel 4 to 5 hours. And same issues with the roads in the winter, they really don't want to travel. I have found, having now satellite centers. So we do have clinics that are being established in those places by nurse practitioners, advanced providers, and just outreach clinics is what how we're tackling that. And so far, the trickling in of those nodules is still not very streamlined, but I think having some sort of satellite centers and approach to somebody locally, that would also be helpful.
Yeah, I think it's a combination of things. It's a combination of really kind of identifying those folks that do need the screening, but then once a patient sort of is screened and there's a nodule, it's kind of putting them into a program where really the primary care doctors have a resource like an e-consult to sort of, again, reach out to make a decision. Because I think the only way we're going to scale this is really is as we look across the organization is really have the second tier of help for our frontline docs. I would say our primary care docs, our family practice docs. And that's really, taking the program to another level. And there has been discussions about an e-consult, almost like I don't want to say a curbside, but an official sort of consult, but done electronically, doctor to doctor almost.
Sorry, Gary, it looks like I got bumped off by somebody.
Yeah, welcome back.
I think it was somebody who was reading a CT scan and I got bumped off the internet. So can we talk a little bit, a little bit about maybe the false positives that I know, Dr. Pilli, you started to, talk a little bit about. And I think have we seen that rate drop over, because I know as we become more sophisticated at the imaging, and maybe Dr. Coy, this is something you can speak of. I know we can, I was always amazed how you can take the nodule and look at it in 360 and up and down and all different nooks and crannies. Do we feel like the rate of false positives, and by false positive, I mean those that we actually end up biopsying and there's, nothing there to speak of. Maybe Dr. Coy, you could speak to that, and then Dr. Pilli, you can follow up.
Yeah, I think that, clearly, it's just statistically, anybody over the age of 50, I think the statistic is that greater than 50% of the population is going to have a nodule. So the issue is, like, when you do that initial screen, and you can see it in the data, that there's going to be a higher rate of positive findings just on that first initial screen. And so I think there's a couple issues. So one is there's more tolerant. You're right. There's a little bit of art that comes in this, as far as like looking at the nodule and saying, wait a minute, I think this really looks like it's an inflammatory process, or this looks like it's atelectasis. So maybe we should be conservative in how we look at this, not go charging in to try to biopsy it or do a PET, but maybe we should just do a follow-up and see if this thing is going to really stick around or not. Conversely, there's other things in the nodule, whether it's spiculated, and certain locations
the old speculation,
yes, yeah, where's a higher percentage of a higher probability of being neoplastic. I think the other thing, there's greater, on the initial screen, there's greater tolerance for the size of the nodule. So on your initial screen, the size of the nodule, the amount it takes to upgrade the nodule to more active surveillance or stuff has to be a higher size nodule. Once you've been in screening for a while, then those numbers drop down a little bit. So to some extent, it's taken into account by the lung-RADS criteria, and also it should be, as Misho said, if there's a discussion about these nodules, oftentimes when I'm involved in discussions, usually it's more often than not saying, I think we should just wait this out and just see what happens. But I don't know if Suchitra or Misho, you might have some other, from your standpoint of actually doing the biopsies, how that looks to you.
That's a great point. I think, lung-RADS is great. I always pay attention to what lung-RADS guidelines are provided by the radiologist on the CT scan. But that's one component of information. You really have to take this and incorporate what pretest probability of lung cancer does this patient have. And that really, I personally use the Mayo risk calculator for every single lung nodule patient I see in clinic. And we put that in the chart, right? And that incorporates age of the patient. What is the diameter of the nodule? Are they a current smoker or a former smoker? Do they have a PET CT scan with avid nodule or a non-avid nodule? Is it an upper lobe nodule? And does it have speculation? And when you incorporate all of this, it throws out a number. So that number is important. So you take lung-RADS guidelines, you take the pretest probability, and then you make a shared decision making. If they're in that intermediate category, the options are going to be follow-up with imaging, or if they're higher risk, 5 to 65% is a big range. So anybody over 30%, you really have to think about more invasive options when you talk about pretest probability. So I incorporate both lung-RADS and pretest probability, which incorporates clinical factors and shared decision-making, and you make a combined decision.
You're warming my heart. Pretest probability is my favorite subject, and I'm getting all fuzzy. So thank you for that marriage of your pretest probability and the scan is really the key. Sorry, I had to jump in, Misho, and just say how warm my heart is.
I would add one more perspective, though, which is that, for our audience who are maybe not involved with this work on a daily basis, when you scan people, you find all sorts of findings. And I'm not talking about not lung-related findings, but oftentimes you'll find 2 or 3 nodules, and more, incidentally, we are finding these ground glass nodules in our non-smokers that likely represent some sort of a cancer spectrum lesion. And then we watch these nodules over time and try to intervene in a thoughtful and physiologically least invasive way. There's a flip side to that argument, which is when we have the indeterminate nodule, which may or may not be cancerous. We looked at this at Virginia Mason. Our false positive rate of resection was only 3%. And then you have to ask yourself, is that rate too low? Like, are we scanning people over and over with essentially growing cancers, not intervening in a timely manner? And that is why I think a multidisciplinary assessment of these, where we take lung rats as a guidance, but not necessarily as gospel as to what to do, and not cut out every nodule, is probably the right approach. And again, you know, in non-smokers with semi-solid nodules, which is something we'll see more and more of, one has to be especially thoughtful because every intervention leads to physiologic decline, precluding subsequent interventions. And so sublobar resections, you know, we have now also the other thing I would add, Dr. McGinn, is that when we think of these interventions, the types of interventions we do in 2023 are very different.
Very different.
We did, you know, 20 years ago.
Yeah.
And so I'm not saying we should have lower threshold for intervening, but because we have, go ahead.
No, the flip side, and maybe I'll let, you know, I haven't heard from Peter at all, so I'll pick on him next. But so the flip side to all of this, which is we've now flip-sided 3 times, so I'm not so sure what side we're on. You know, the more we hesitate to biopsy because we don't want the false positives, the more we put the burden. Now, the folks on your panel, I would always argue the most important person would be the primary care doc on your steering committee, because they work with the bulk of your patients, because the bulk of your patients don't get biopsy. They end up in the lap of a primary care doc who's now got a very anxious group of patients because we said, we don't think it's cancer, let's wait and watch. And then now that creates a cadre of thousands of patients across the United States who I have cared for, who are extremely anxious to the point of depression, where we've had to treat patients with antidepressants to get over their anxiety about the lung cancer screening follow-up test that they have to go through. So, you know, there's this interplay and this dynamic of, you know, we don't want to biopsy, we want to follow. But if we say we want to follow, we're going to induce anxiety and we're going to induce depression. But if we go to biopsy too quick, some people argue with me, let's go right to biopsy and get it over with. Like, come on, why are we going to torture people for years? I'm not advocating that, but I've heard people say that. And I'm like, so it is an interesting interplay. And if you've been on the primary care side of this equation, it's a lot of hand-holding. But anyway, I don't want to go too far on that. But Peter, do you have any? I know you've been quietly sitting there, that you're in the center square for me.
A couple of thoughts to that. And certainly of the patients you say we're going to watch, there's always going to be a proportion of those patients who say, I'm not willing to watch. And if you're not going to biopsy me, I'm going to go find somebody else who will biopsy me. And so we have to, you know, guide that. The other thing that I was going to add, because it's been in the news recently, is for all of the primary care physicians listening in on this, is to focus very much on Dr. Pilli's stats. And remember, this is low dose CT. This is not regular dose CT. And the reason I say that is there's a big news flash. I can't remember the percentage, but one regular dose CT increased the risk for heme malignancies like dramatically. This is not that bird. This is low dose, and as we counsel patients in the primary care clinics, we have to point out to the patients that it is low dose, not regular dose.
That's a good point. I think a lot of the data is looking at CT angios for PE and things, and that number is increasing a bunch of, you know, getting people very nervous. So I think that gets mixed up with some of this. Gary, any closing thoughts, or how do you want to finish this up?
No, this is great. There's one question in the chat, and it kind of goes back to something Dr. Pilli said about, look, if we follow EPIC, in this case guidance, I think we'd have 31.9% folks eligible for screening, but if we follow other guidelines, it's up to 67%. And there's a question in the chat, and John Chelico, I think this is a good question for you as well. What is the system doing to solve the PAC-year EMR problem? Best source I see is PFT system data.
Big problem.
So, I mean, it is. And so I don't know. And just to say, John has been working very closely with us in terms of robotic automation to find these people in the first place, but I don't know that it will address this problem.
Look, I mean,
Go ahead,
I think there's a patient input piece. I mean, I think we need to get the right data from our patients, and I think that we need to be more accepting and more advocates of getting the data directly from our patients in order to inform the PAC year history. But really building upon what Dr. Misho and David are doing in the Pacific Northwest, what Dr. Pilli is doing now in Nebraska, using the robotic process automation to really kind of get it automated to the point where our primary care doctors are not sort of thinking about this, but it automatically happens. And I think that is sort of the next step of how we can surely operationalize this. We've seen just amazing success and so far what's happened in the Pacific Northwest.
So I think, Tom, we're probably at a good
Yeah,
pause
I think
here.
it's a great space. I know Gary will thank everybody, but first of all, it's always great to meet such fascinating leaders that we have in CommonSpirit, and also introduce you guys to each other sometimes. And I know there's a huge effort of, a huge opportunity here for us to be smarter at this. I know Dr. Chelico and Ankita and Gary are working on standardizing our primary care screening tools so that they're more automated, and partnering with everybody here to make that happen, I think is critically important. And then have the infrastructure behind all that screening to actually manage this, because that's where life gets complicated. So appreciate all the efforts. And Gary, I'll hand it over to you to say.
Yes, I would. Yeah, thanks, Tom, and I want to thank all of our speakers and panelists. There is an occupational hazard to being on this presentation, and that is we are most likely going to call you up again to ask you to help us sort of map this out across the country and have a way that we're standardizing care, and that we've got multiple sites that collaborative, particularly for people who live on the other side of the mountain. So for that, we thank you in advance. And great conversation this morning, great presentations. We appreciate all of that. And for our attendees as well, thanks for sticking with us, and thanks for being here. Again, this is our last CME for this year, but I think John put in the chat what we have coming up for next year, and there will be more and more of that. So we thank you all. We appreciate it. At the end of the day, this helps people be healthier longer, live more rich lives with less debility. So we think that's all good. And we wish everyone a very healthy and happy holiday season, and a safe one. So with that, we appreciate it, and more to come.